Hello and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am so happy to be joined by Dr. Donald Warne, who is also a Read Scholar. Dr. Warne is a family medicine physician and currently the Associate Dean of Diversity, Equity, and Inclusion, as well as the Director of the Indians into Medicine and Master of Public Health Programs, and also a professor of family and community medicine at the School of Medicine and Health Sciences at the University of North Dakota. That was several mouthfuls, sir. Thank you so much for being here. How are you?
Doing really well, and so happy to be here. Thank you so much for asking me to be a part of this series. Doing actually really well. I mean, it's a difficult time in history with the pandemic, with economic issues and political issues, but in my little corner of the world, things are actually moving along pretty well.
It has definitely been an interesting year for us all, and I know your plate has been super heavy, so we appreciate you carving out a little time for us. I thought it would be a great place to start for our listeners to just kind of understand a little bit more about you, what led you into medicine, what led you into family medicine in particular, and how you then transitioned into the health equity space.
Yeah, well, I'm originally from Kyle, South Dakota on the Pine Ridge Indian Reservation. And it's a very small community within a very impoverished reservation in southwestern South Dakota. But when I was in grade school, we actually moved to Arizona. So I grew up near Phoenix for most of my childhood and early adulthood. But in the summers, I would go back to South Dakota. So growing up, my brother and I just assumed all kids went to South Dakota for the summer, but it turns out that's not the case. But that's how we grew up. But it was a wonderful way to grow up because I was able to stay connected culturally to my people in South Dakota, but also I wasn't immersed in some of the socioeconomic challenges and the substandard educational systems and the challenges that creates. So for me, it was just, I was very fortunate in that I had that opportunity to blend understanding the best of what our culture has to offer, but then also being able to go to better school systems, quite frankly. Yeah. In the 1970s, the school systems were not, they were not thriving in the reservation communities. And I certainly wouldn't be where I am today had I grown up there. Isn't that sad that I'd actually stayed in my home community? There's no way I would have made it to medical school. So when I moved to Arizona, I wound up going to Arizona State University for our undergraduate. And during the time frame when I was going back to South Dakota, I have a lot of uncles who are medicine men and traditional healers. Mm-hmm. So I'd spend a lot of time with them and learning the language and, sorry about that, learning the culture and learning our traditional ceremonies. So growing up, it was really a wonderful opportunity to stay very well connected to the culture. And I was actually being trained in traditional Lakota medicine from a more traditional cultural perspective. But I was doing well in college. And I remember at ASU, there was a pre-med program. And the pre-med advisor was really committed to promoting diversity among the pre-meds. So I was doing well in sciences, and he asked if I had ever considered going into medicine. And my first question was, are there any American Indian physicians? I mean, I had never met one, you know? So it never had occurred to me that that would even be a possibility. So he said, well, of course there are. There weren't many, but at the time, my mom was a nurse with the Indian Health Service, and she knew of one American Indian guy who was a physician. And when I met him, that was really kind of life-changing, because then it finally seemed real. And I'm sure many of our Read scholars have had similar experiences, but I think if you're from the dominant culture and society, and all of your teachers, principals, doctors, and professionals that you engage are from your race or ethnicity, then anything seems possible. But for me, it didn't seem possible until I actually met an American Indian physician. And at that point, I felt very encouraged that this is something that I could do. As a kind of a side story, I was actually worried that my uncles would be disappointed in me, you know, because going into traditional medicine, and I've heard all the stories about how traditional cultural practices are in many ways disrespected by modern medicine and modern society. So when I told them about that, I was concerned that they would be discouraging, but actually the opposite happened. And one of my uncles, his name was Ray Tixborg on it. He said very specifically, I think this is a good idea, But if you do this, never forget where you come from and never forget your responsibilities as a Lakota man. And our responsibilities, we don't go into professions just for self-development or personal reasons. It's about our community and about our people. So that's why I really wanted to dedicate my work and my career and my life to doing whatever I can to improve outcomes for American Indian people. So that's kind of what led me to medicine.
Thank you for that. Was a wonderful story. It's always nice to hear people reflect about. Sometimes, I mean, I'm sure we do it to ourselves sometimes, but not always out loud. And knowing there could have been a few small decisions by not even us, right, by our parents that could have led us down a very different pathway. And recently we've been talking about a lot about empathy, right? But I think when we have this diversity of experiences, not just, we talk about diversity in a broad sense, but within your person, you have a diversity of experiences, and that I think translates to your profession and how you interact with people and makes you a better clinician or whatever you're doing in life. And kind of taking that one step further, I know you talk a lot about this intersection of history, of science, of policy, right, and culture. And I think in our current state of affairs in the U.S., all of those are clashing head on. And so we're still in the pandemic, unfortunately. And I know that there are definitely populations that have been harder hit than others because of some of these social determinants of health that we haven't that are being highlighted, we should say, from COVID-19. So can you speak a little bit more about that and the communities that you're especially worried about, and why as they relate to COVID-19?
Absolutely. And this does link to exactly what you're talking about with history and culture and all of those dynamics, ultimately having an impact on things like social determinants of health, but also risk for bad outcomes. And what really led me down the path toward health policy and equity was that in my own experience as a primary care doctor in the Indian Health Service, I felt like we had such limited tools, that we didn't have enough tools in the toolbox because IHS is so terribly underfunded. I know a lot of people work in the Veterans Health Administration. Our funding in IHS is about half per patient of the VA. So just imagine trying to be successful within that dynamic. So that was my big frustration in medicine, is that I knew there were other tools that we could use, but I did not have access to them, and I wanted to know why. So that's really why I went into public health and health policy, because there are reasons why we don't have access to those resources. But for Indian Health Service, there's some interesting historical dynamics. As American Indians and Alaska Natives, we are unique in that we are the only population born with a legal right to health services. And that's based on treaties in which the tribes exchanged vast amounts of land and natural resources for various social services, including housing, education, and healthcare. So that's why we have a Bureau of Indian Affairs. That's why we have an Indian Health Service. Those are the federal agencies that are responsible for delivering those services based on the treaties. So there's hundreds of treaties, and some typical language in the treaties includes that we will exchange land and natural resources for promise of all proper care and protection. So promise of all proper care and protection. So when we look at the treaties, and if we think of those as a contract, the US government is in breach of contract when it comes to Indian healthcare. So the years of underfunding have led to a dynamic where our public health infrastructure is just severely inadequate. So through the Public Health Foundation, they've done a lot of work trying to understand the components of public health infrastructure and what works effectively. So as a side note, I'm on the National Board of Directors for Public Health Foundation based in DC, which I think is the virtual screen behind you, actually. Yeah. But they have, I think, a really good model for understanding public health infrastructure. You have to have adequate workforce, you have to have good information and data systems, and you have to have buildings and equipment, that type of physical infrastructure. So I like that model because it's kind of almost a biological model. The workforce is the muscular system, the data systems are the nervous system, and the organizational capacity, like buildings and equipment, that's the skeletal system. So you need to have that to build laboratory capability and to build surveillance and all of those things that we take for granted in public health. But in Indian Health Service, because of the decades of underfunding, our infrastructure is severely inadequate. So we don't have the workforce that we need. We don't have the laboratory capability to do all the testing that we need. Our information and data systems are not compatible with any other system. Actually, the database for Indian Health Service is called RPMS. It's a Resource and Patient Management System. That database was built in the 1970s, actually by the VA.
Wow.
And they use a computer language that's now extinct, but the only people using it are Indian Health Service clinicians. So it's a very difficult circumstance. So when you have a pandemic, and this is a once in a century pandemic, our ability to respond appropriately is severely limited. So you can see how history and policy decisions and funding decisions and actually racism has led to a dynamic in which the tribal populations are at a severe disadvantage when it comes to responding to the COVID-19 pandemic. So the result is that we have worse outcomes in tribal communities. So we know that we have higher rates of infection, but also higher risk for infection because of things like overcrowded housing and a lot of pre-existing health conditions that put us at risk, higher rates of diabetes, higher rates of heart disease, higher rates of lung disease. And CDC put out the publication through MMWR that if you have any of those conditions, you're at 6 times greater risk for hospitalization and for death. And we have higher rates of all of those compared to other populations. So it's multifaceted. It's the decades of neglect and lack of infrastructure combined with a pandemic, combined with impoverished communities, all within the context of systemic racism. So no wonder our outcomes are bad. And some communities have been just devastated by COVID-19. Navajo Nation in Arizona, they have the highest per capita infection and mortality rate right there in a rural reservation in Arizona. But some of the communities where I work in the Dakotas are not very far behind. So you can just see how all of those things linked together. And I love family medicine and I love seeing patients, but we're not going to resolve that type of a problem in the clinic or in the hospital. That has to be done in the policy sector. Hence, that's why we do what we do, right? Through the Reed Scholars programs.
Definitely. And, we talked to Ann Newland, who's out in Arizona earlier in the pandemic, and how she was trying to negotiate some, especially well, in all honesty, I've never been to North Dakota, but I know out in the Southwest, geography is also an issue, right? Because we're talking about large states with large land masses that aren't often accessible as well, in addition to all these other things. So when we talk about policy changes and how we can best affect vulnerable populations, one of the strategies is to increase the workforce development to include people who look like the people that they're going to serve or come to their community or have a familiarity with the community. And to your point that you made earlier, even though you lived in Arizona, you still had this connection with South Dakota and you understood from a lived experience what that community needed and had to deal with. So I know part of your work, your long-term work, but even recently, is being able to develop programs that increase that capacity in academic training. So you tell us a little bit about your programs there and why you decided that it was important, and how do you go about encouraging people when, again, they might not see an MD or PhD or DO or whatever in their community.
Yeah, and as we all know, in our communities, the messenger really matters. And if you have well-trained people from other communities trying to impart health recommendations or health education, it's just not nearly as effective when it comes from our own people. So there's really measurable impact in terms of the need for a diverse workforce to effectively send messages, do it in a culturally competent way, but also to influence health-related behaviors. So it's vitally important. And when we think of underrepresented minority populations, American Indians are the minority of the minority populations, and we're the most underrepresented of the underrepresented populations, unfortunately. So we're around 2% of the overall population and about 0.3% of physicians. Really remarkable, just so few of us. So I've been working in this space for quite a while now, and I'm now associate dean at the medical school. And those of us in academics kind of know the pecking order of things like professor, associate professor, assistant professor, then there's dean, associate dean, assistant dean. So in the United States, well, guess how many medical school deans are American Indian? Do you have any idea?
I'm gonna go with one.
It's less than that.
Maybe there's one.
Yes. You can count the American Indian medical school deans on 0 hands because there are none. Isn't that remarkable? This is 2020, and this is
2020.
So in terms of associate deans, there's 2 of us. I'm 50% of the American Indian associate deans at medical schools. And that's not a pat on the back, that's an indictment on the field. You know, it's terrible that it's this way. So we do have a handful of assistant deans. When we look at tenured full professors of medicine, this is out of many, many thousands of professors. I believe there's 39 or 40,000 professors of medicine, full professors. Of that number, there's 16 American Indians. So 16 out of about 39,000. Wow. And I'm one of those. So I'm 1/16 of the professors of medicine, tenured full professors, which is just a travesty. So talk about underrepresentation. So one of our challenges when we're trying to recruit more students into pathways toward medical school and public health, the challenge is we don't have enough role models, quite frankly. And what I experienced and what I see is that there's quite often a huge pressure on our students to go into primary care, and that's wonderful. Right, we need primary care physicians, but we also need researchers, we need specialists, we need academics. And as American Indians and probably other populations too, but we knew as pre-meds where the Indian-friendly universities were, the Indian-friendly medical schools, because there are some that are just clearly not. And I think the challenge with lack of diversity among university leadership and medical school leadership is that you're at risk for group think, and you don't know what you don't know if there's no diversity of thought. Yeah. And I see that repeatedly. So I was very frustrated by this in mid-career, and I was executive director of what was called the Great Plains Tribal Chairman's Health Board. And it was, it still is in existence. I still serve as the senior policy advisor to them, but it's a group of 18 tribal nations in the Great Plains of North Dakota, South Dakota, Nebraska, and Iowa. And in that experience, I was really disappointed in the MPH graduates, for example, who knew nothing of American Indian public health issues or the policy basis for IHS or tribal programs. And even at Harvard, quite honestly, I was impressed with what our professors knew about Southeast Asia or Sub-Saharan Africa. But in truth, even at Harvard, there's very little understanding of what's happening in Indian country. So it's just kind of not on the radar. And I don't think it's due to malicious intent, it's just people don't know what they don't know. So I had the opportunity about 10 years ago to join North Dakota State University in Fargo and start the very first American Indian Public Health MPH specialization. And that went really well. And we have, probably 40 or 50 graduates of that program, very happy with that. So a lot of my former students are in high-level positions now in the region in public health, which is just wonderful. But about 2.5 years ago, I had the opportunity to move to University of North Dakota in Grand Forks. It's only about 70 miles away. But this is where the medical school is located. And I was offered a position to run the Indians into Medicine program and to be Associate Dean. And I couldn't pass that up. It's Associate Dean of Diversity, Equity, and Inclusion, and to run an American Indian focused medical training program. Kind of my ideal job, So I've been here for about 2.5 years. And in the interim, the previous director of the public health program retired, and they asked if I would take that on as well. So that's why I have 4 hats at UND. But I was more than happy to do it because one of the things I also see that's missing from the educational arena is good training in Indigenous research methods, Indigenous evaluation methods, Indigenous leadership and ethics, And all of these areas of focus that we really need to bolster. And what better place to do that than here? So for our InMed program, that's actually been around since 1973. And what's exciting about that, our second year students in InMed are the class of 2023. So they're the 50-year anniversary class of InMed. And we've graduated now about 250 American Indian physicians out of InMed programming. This year, we have 8 first-year medical students who are American Indian and Alaska Native. Wow. And we started the new PhD in Indigenous health this year, so in 2020. And we're hoping that we'd maybe have 12 students interested in the program. We're hoping for a dozen. We wound up having several hundred inquiries, but we wound up having about 50 completed applications of really high qualified people. So our initial cohort of PhD students is 19, and of the 19, 17 are American Indian. So if we look at 8 first-year medical students, 17 first-year PhD students, at our little School of Medicine and Health Sciences here in Grand Forks, North Dakota, we have 25 American Indian first-year doctoral students right here. So it makes me feel hopeful for the future in that we need this level of training and expertise throughout the country. And we do offer it through distance education using Zoom. So we have students in Washington State, Montana, North Dakota, South Dakota, Nebraska, Iowa, Minnesota, Missouri, Arizona, New Mexico, Canada, and also Maryland. One of our students works at the IHS headquarters in Rockville, Maryland. So I'm very pleased with how those things are coming along. But it really is going to take a generation of well-trained public health and medical professionals to have a real impact on reversing some of the disparities that we see. But I feel like we're on the right path. So even within the context of all the challenges we're dealing with, from COVID and economic implications and political challenges, I feel really good about where we are in terms of our Indigenous health training at UND.
And you know, I listen to you and I'm so impressed because I see you as a visionary who also, when vision meets execution, right? So you're not just hopeful about things, you try to figure out how to make it better and how to make it better for the most people. And having 25 first, I mean, that's amazing. And especially if you look at how many other are there in other schools across the country. So congratulations on that.
Thank you.
So I know I can't hold you much longer. So as we come to the close, I want to repeat a statement that you said earlier about the language that was in the earlier treaties about the promise of proper care and protection for all, right? And so as we close, as we think about the COVID pandemic, as we are trying to be optimistic about the future, what can you leave us with? What are your thoughts about the best way to move forward, or what are you looking forward to kind of as we move hopefully to the other side of this?
Well, I know that all of our populations are dependent on programs within the Affordable Care Act. And as we record this, of course, we're still waiting on a Supreme Court appointee and a Supreme Court decision on the ACA. If we lose the Affordable Care Act, that would be devastating to our populations, including American Indians. You know, we have a lot of poverty, and in the Medicaid expansion states, we have a lot of people who are taking advantage of Medicaid expansion in the marketplace. And we've seen significant increases in access to health insurance in the states that have expanded Medicaid. So I think collectively we can work in mutual advocacy toward preserving and expanding things like ACA related programs. But I think even above and beyond that, let's try not to exclude Indigenous perspectives from the broader discussion. And you know, I've always been impressed with our colleagues in the Reed Scholars Network, that we really do have a deeper understanding of each other's needs and issues and histories. But I come across circumstances quite frequently where the Indigenous issues are not even addressed. And in one of my previous roles, I was on the American Cancer Society National Board of Directors. And Dorado Brooks had been working there for a long time. He was, of course, one of our Reed scholars as well. But I'm the only American Indian physician to ever serve on the national board. And again, that's not a pat on the back, that's an indictment on the field. And ACS has been around for over 100 years, and I'm the only one. So I've rotated off the board since then. But one of the things that we were able to do when I was on the board is to start including American Indian data in their data sets. But when I got there, it was white, Black, Hispanic, and other. So we're just, other, lumped in with everyone else. So at least that has been able to change. I work in a number of national organizations. I'm also on the March of Dimes National Board of Trustees. I think quite often the disparities that are faced by Indigenous people are just not even addressed, not even part of the conversation. So as we move forward in shared advocacy, let's ensure that there is a Native voice at the table that can actually be a part of advocating on behalf of each other, but let's make sure we don't neglect issues unique to the first Americans.
Thank you so much. I think that is a perfect place to end. I'm not even going to say anything else after that. I really appreciate you being here. Again, I'm always impressed by all the things that you do, and good luck with all. I'm sure there's going to be more new things on your plate as the year continues to evolve. So, but thank you so much.
Thank you. Appreciate it.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.